clinical neurology. And in order to do this, we're going to show some isolated spinal cord sections and indicate by the green shading where the problem is. And in our conversation, we're going to talk about what the cause of the problem is, whether it's a vascular insult, a degenerative disease, a demyelinating condition, or what have you. And the first of these neurologic conditions typically results in a bilateral selective loss of just lower motor neurons. This can be a manifestation of poliomyelitis, where the lower motor neurons are destroyed by the uptake of the poliovirus from involved skeletal muscle that through retrograde axonal transport destroys lower motor neurons, commonly in the lower limbs because of the lumbar involvement of the lower motor neurons. Or it could be a child born with a form of a spinal muscle atrophy that creates a condition known as floppy baby because of the lack of activity or the degeneration bilaterally of lower motor neurons in this unfortunate infant. So again, in patients that develop lower motor neuron disease, pure lower motor neuron disease, we're going to have typically bilaterally all the signs and symptoms of flaccid paralysis. We're going to have suppressed or absent muscle stretch reflexes, and if the degenerative process is complete, we will see fasciculations followed by muscle atrophy. Fasciculations followed by muscle atrophy. So this is a classic degenerative process or a genetically based process where the lower motor neurons are selectively affected at spinal cord levels. Then, obviously the result is a bilateral flaccid paralysis with accompanying suppressed or absent muscle stretch reflexes, fasciculations, followed by atrophy. Now then, our next neurologic condition is known as tabes dorsalis. And this is a very different condition that is a late-stage manifestation of neurosyphilis. What this is a progressive demyelinating disease that disrupts the myelin of myelinated, more heavily myelinated than lighter myelinated incoming dorsal roots. So this is going to have a dramatic effect by demyelinating the incoming tactile and proprioceptive dorsal roots that are entering, as we know, and are attempting to turn upward in one of the dorsal columns that are conveying tactile and conscious proprioceptive information to the cerebral cortex. So classically, this progressive demyelinating condition presents with what neurologists call the 3 Ps of tabes dorsalis. They present first off with paresthesias of tactile modalities. They present classically with a pins and needles sensation bilaterally in the lower limbs because the demyelination effect tends to affect lumbar cord levels rather than cervical cord levels. So it's demyelinating the dorsal roots and the axons bilaterally in the fasciculus gracilis bilaterally. So the patient presents with altered sensations, pins and needles, or altered vibratory sense bilaterally in the lower limbs. When they walk, they frequently complain of walking in pain. Why are they walking in pain? Because the demyelinating effect also affects the myelinated dorsal roots that are carrying pain sensations in from the lower limbs. So the altered sensations created by this demyelinating condition cause the patient to walk in pain even though they're not typically enduring a painful stimulus, because the pain-carrying dorsal roots are also affected in this demyelinating condition. And lastly, the sensory neurons that detect bladder fullness are also affected in this condition. So this patient might present with polyuria. Remember, this patient doesn't know, because of their demyelination of the sensory innervation of the bladder, they don't know when their bladder is full. So patients with this condition might do one of two things. They might increase their urinary output, developing polyuria, or they might retain urine and have urine retention. And typically the polyuria fits one of the 3 Ps of the classic signs and symptoms of tabes dorsalis. Then, not only does the cerebral cortex not know where the limbs are in space, remember where else these proprioceptive dorsal roots are going. They're also going to the cerebellum because they're coming in and synapsing in Clark's nucleus, and Clark's nucleus is projecting spinocerebellar information to the ipsilateral cerebellum. So not only does the cortex not know where the limbs are in space, the cerebellum is also not getting the proprioceptive information. And as we alluded to earlier, when we have a disruption of proprioceptive information to the cerebellum, the patient will present with a positive Romberg sign where they will sway or lose their balance with their eyes closed, So then, not necessarily last but not least, remember what is another role played by the 1A dorsal roots. They project down and they synapse directly on lower motor neurons as part of a muscle stretch reflex. So if you demyelinate the 1A dorsal roots that are entering in the dorsal, basically entering the spinal cord at lumbar levels, the patient is also going to have suppressed muscle stretch reflexes bilaterally in both lower limbs. Because again, you are demyelinating and affecting everything that the proprioceptive dorsal roots are doing. They are projecting to cerebral cortex, so the cerebral cortex doesn't know where the limbs are in space. They are projecting to the ipsilateral or the cerebellum bilaterally in this case, so the cerebellum doesn't know where the lower limbs are in space. So the patient is going to walk with a broad-based ataxic gait. They're going to have a positive Romberg sign, and they're going to have suppressed muscle stretch reflexes. So when this patient walks, they don't have any weakness because, again, since they are afraid of falling over, patients that have tabes dorsalis, where the cerebellum has been deprived of its sensory input, have what is called a sensory ataxia. And we will contrast this with a patient with actual cerebellar lesions that will present with a motor ataxia. But the patient with a motor ataxia and a cerebellar lesion will not have a Romberg sign because they will tend to sway or lose their balance regardless of whether their eyes are open or closed. Then last but not least, nobody fully understands why, these patients with tabes dorsalis also present with an interesting pupillary light reflex abnormality known as Argyll-Robertson pupils. Argyll-Robertson pupils. These are pupils that constrict in what we call the near response, but don't constrict in response to light. And we'll talk about the manifestations of this lesion when we deal with the visual system, but it's thought to be the result of a specific area of demyelination way up in the upper end of the midbrain where the light reflex is generated. It seems to be a long way away from the site where we're losing myelin axons of a respective dorsal column. So again, remember, patients with tabes dorsalis have obviously all these lower limb problems, sensory ataxia, Romberg sign, and so on and so forth, but they also will have a very specific pupillary reflex abnormality known as Argyll-Robertson pupils. So again, just in summary, we know that tabes dorsalis is one manifestation of a patient that has neurosyphilis, and we documented how they present with the 3 classic signs: paresthesias of vibratory sense, pins and needles sensation, pain, and polyuria that's associated with a disruption of the myelinated axons entering lumbar spinal cord that are trying to reach and course upwardly to the cerebellum in the dorsal columns and also are being deprived from the reflex connections with lower motor neurons. So again, the lesions involve bilateral degeneration of the myelin of the dorsal roots. And obviously, it's those dorsal roots that are projecting into the dorsal columns at the same axons. So we're losing or demyelinating the axons in both of the fasciculus gracilis dorsal columns because the demyelinating effect is more common at lumbar cord levels than anywhere else in the spinal cord. So these patients, as we say, have impaired vibration and position sense. They may obviously have a decreased ability to obviously recognize where their lower limbs are in space. They don't really have astereognosis so much because that's an upper limb problem. They have paroxysmal pains because they walk as if they're in pain because of the effect of demyelinating the incoming pain-carrying dorsal roots. And they classically have what's called a sensory ataxia. They walk with a broad-based gait because they're afraid of losing their balance because of a lesion or a loss of sensory input to the cerebellum. And again, they will have suppressed muscle stretch reflexes and a degree of urinary problems, not so much incontinence, but they'll either have polyuria or retain urine as a result of the loss of sensory input that's emanating from the bladder wall itself. So, and then lastly, again, these patients are unsure where the ground is because they don't have a conscious awareness of where their limbs are in space. The cerebellum doesn't know where their limbs are in space, so they will walk with a broad-based gait. And when they walk, they tend to raise their lower limbs a little higher off the ground in what's called a high step stride, again, because they are unsure of where their limbs are in space and unsure how high they have to lift them off the ground in order to make a step forward. Now then, our third spinal cord condition is known as amyotrophic lateral sclerosis. This is a devastating degenerative neurologic condition that results in a bilateral loss of both upper and lower motor neurons. Upper and lower motor neurons at a specific spinal cord level. Commonly, the degenerative process occurs in the cervical enlargement, in the area of the brachial plexus. And what we see, let's assume this is a cervical spinal cord section in the diagram that's shown over here on the left. What are we going to see in this hypothetical patient? At cervical levels, there will but at least be a bilateral loss of lower motor neurons in the brachial plexus. So what are we going to see bilaterally in the upper limbs? Flaccid paralysis, suppressed or absent muscle stretch reflexes, fasciculations, and atrophy. But at the same time, we will have lesion the corticospinal tracts in the cervical spinal cord. So what are we going to see bilaterally below the lesion? Assuming the lesion or the degenerative process is occurring in the cervical enlargement. We're going to see spastic weakness everywhere bilaterally below the lesion because we are lesioning the corticospinal tract in the cervical spinal cord. And if we lesion it, we deprive all of the lower motor neurons everywhere below cervical cord of their upper motor neuron innervation, and the patient will present with a spastic weakness bilaterally below the lesion, including increased tone and reflexes and bilateral Babinski signs. Bilateral Babinski signs. Okay. The disease specifically begins at cervical levels and tends to be progressive. If it moves up through cervical spinal cord into the brainstem, it's going to affect the patient's ability to swallow, and obviously they will lose control of lower motor neurons and cranial nerves, a more devastating effect. If it moves up the cervical spinal cord, the degenerative process will also affect the phrenic nerves and obviously denervate the diaphragm, and that obviously is not going to be a good condition. However, if the disease progresses down the spinal cord, the patient will be wheelchair bound, but they're going to live a whole lot longer than if the disease process moves up through cervical spinal cord and into the lower part of the brainstem. Okay, so classically a patient with ALS presents with bilateral flaccid weakness at the level of the degeneration, and if the degeneration is occurring in cervical spinal cord, the flaccid weakness will be bilaterally in the upper limbs. But if we are lesioning again the corticospinal tracts in cervical spinal cord, there will be bilateral spastic weakness everywhere below the degenerative site, including bilateral spastic weakness, upgoing toes bilaterally in the lower limbs, And again, if the disease process moves cranially, the phrenic nerve neurons in upper cervical spinal cord be affected, and brain stem cranial nerve nuclei will be affected, having a devastating effect on the ability to swallow and breathe, obviously conditions that are not compatible with life going forward. All right, then, what's going to be different about an occlusion of the anterior spinal artery? So this condition will present with some of the signs of amyotrophic lateral sclerosis, because what that anterior spinal artery supplies is the ventrolateral portion of the spinal cord. The ventrolateral portion of the spinal cord. And if it occurs commonly at thoracic levels, like a patient with ALS, the patient will have bilateral spastic weakness below the lesion, bilateral flaccid paralysis at the level of the lesion, but what distinguishes a patient with an occlusion of the anterior spinal artery is the patient will have, in addition, a bilateral loss of pain and temperature, because the anterior spinal artery supplies all parts of the spinal cord bilaterally except for the dorsal columns. That's the exception. So, in addition, because of the bilateral involvement, if we lesion the spinal cord white matter bilaterally, anywhere above sacral spinal cord levels, the patient might develop what's called a spastic bladder. A spastic bladder basically is a bladder that has functions in response to a disrupted upper motor neuron. Because in a way, the upper motor neurons that project down from the brainstem to the bladder, in essence, inhibit the bladder emptying reflex and allow the bladder to fill. So if there is a bilateral loss of the upper motor neuron inhibition of the bladder emptying reflex, the patient will develop urge incontinence. They will constantly feel the urge to empty a partially full bladder, resulting in what's called a spastic bladder, as we see here. So the clinical correlate associated with spastic bladder is this. It has to result from a bilateral lesion of the spinal cord above sacral spinal cord levels. It can be a manifestation, as we've seen, of a blockage of the anterior spinal artery that supplies the ventrolateral aspect of the spinal cord, all except for the dorsal columns. And basically now we are losing the inhibitory control of bladder emptying. So the patient develops a hyperactive or a spastic bladder where the parasympathetic neurons that innervate the detrusor are elevated and activated superficially because of the loss of the upper motor neuron inhibition of the bladder emptying. So as a result, as we've said, the detrusor responds to a minimum amount of stretch, causing urge incontinence, which is a classic manifestation of a bilateral lesion of the spinal cord above sacral levels that's associated with a spastic bladder. But then, to finish the bladder story, where will the lesion site be in a patient that develops an atonic bladder or a flaccid bladder? This is the result of a direct lesion to sacral spinal cord or to the pelvic splanchnic nerves, the parasympathetic nerves that actually control contractions of the detrusor muscle bilaterally. So again, this has to be a sacral spinal cord lesion that specifically lesions the pelvic splanchnic nerves. So now the bladder will fill completely, but we cannot empty the bladder because of the paralysis of the detrusor muscle bilaterally. So this is a patient that develops a flaccid or an atonic bladder. The patient is going to be catheterized because of the infection risk, and there'll be constant dribbling of urine from the bladder, because if we lesion sacral spinal cord, the likelihood is that we've not only lesioned the pelvic splanchnic nerves, we've also lesioned axons of the pudendal nerves from the same spinal cord segments that are innervating the voluntary sphincter that maintains urinary continence. So the patient's bladder will fill completely, but they will be constantly leaking urine because of a weakened sphincter, and they won't be able to empty their bladder because of the loss of the parasympathetic pelvic splanchnic innervation of the detrusor muscle. And then, last comment we've seen earlier, what's different about a patient that develops an infantile bladder? Now, where is the lesion? This is a lesion, probably the result of a manifestation of a patient that has normal pressure hydrocephalus, where now in this elderly patient, the increased volume of CSF compresses bladder control neurons on the medial aspect of each cerebral hemisphere, developing what's called an infantile bladder, where now the bladder fills normally and at the proper amount because the upper motor neurons emanating from the brainstem work, but the bladder empties at the wrong time and place because of the loss of cortical control, created or seen commonly in patients with normal pressure hydrocephalus. So those are really the three bladder conditions. Infantile bladder is a cortical problem. A spastic bladder is a bilateral spinal cord lesion somewhere above sacral spinal cord. An atonic or a flaccid bladder results when there is a sacral spinal cord lesion specifically, or a lesion to the nerves that are forming the pelvic splanchnic nerves and or the pudendal nerves simultaneously.